Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
We want you, yes, you, to join the Behind the Knife team as a surgical education fellow. We're looking for enterprising surgical residents to take the bull by the horns and build something new and exciting. Fellows will benefit from ample support from the Behind the Knife team, including the use of our digital education platform and access to all of our resources like illustrators, video editing, AI tools, social media, and more. Get your name out there and build your CV by being part of the #1 surgery education platform in the world. We're offering a 2-year fellowship starting in July 2026 and ending in June 2028. Only residents beginning their 2-year academic development time will be considered. Check out the show notes for more information, including the application link. All applications are due on April 20th. Again, all applications are due by April 20th.
Greetings, everyone. Welcome to another HPB episode on Behind the Knife. This is your HPB team coming to you from Stanford University in California and Massachusetts General Hospital in Boston. I'm Anish, a PGY4 general surgery resident here at Stanford, and I'm excited to be joined by a great friend and mentor in Dr. Jon M, a former HPB fellow at Stanford and current HPB faculty at MGH. Today's topic is pancreatic cysts. We'll discuss the different types of pancreatic cysts, how they're diagnosed, the workup of these various cysts, and how it changes based on our suspicions and when surveillance versus resection is appropriate. So before we jump into all the details, Jon, I think the best thing to start with is your classification of pancreatic cysts. And you've done this a few different ways for us. So could you just break it down into, benign, the mucin producing, the non-mucin producing, and then the epithelial or malignant cysts as you've classified them for us?
Yeah, it's great to be here, and thank you for inviting me back. I think cyst topic is a really confusing topic for trainees because there's a lot of different ways that the cysts can sort of present themselves, and how they get managed is variable, and understanding when to operate is really sort of the heart of it. And I do sort of break it down into a dichotomy of mucin-producing cysts and non-mucin-producing cysts. And within the mucin-producing cysts class, you have MCN, which is Mucinous Cystic Neoplasm, and IPMN, which is intraductal papillary mucinous neoplasm. And they are important as a separate sort of grouping because the mucinous cysts have malignancy potential. These are the ones that can transform into cancers, and your sort of approach to them has to be through an oncologic lens. The other cysts are non-mucin producing by definition, and they have a varying degree of malignancy potential from 0 to very real, and that is sort of dependent on what the cyst type is. So whenever you're confronted with a cyst, getting really good high quality axial imaging is important to sort of differentiate between mucin producing, non-mucin producing, and then adding other sort of workup adjuncts. And when you can prove that it's a non-mucin producing cyst, you're then dealing with a pseudocyst, which a patient should have a strong family history, a strong sort of clinical history for pancreatitis in the past. It could be a serous cystadenoma, which again is going to have sort of a clinical footprint that's going to guide you down that sort of route, as well as radiographic features that are going to suggest that. You can have a solid papillary neoplasm, and again, a clinical history is very strong for that. And of those three that I just mentioned, the SPN is really the only one that has malignancy potential. There are case reports of serous cystadenomas having a carcinoma component, but if that's the case, they're by definition not pure SCAs. They probably have some mucinous feature to them. So that's my big sort of 30,000-foot view approach to cysts. And it sort of works its way to this breakdown between mucin producing and non-mucin producing. And of the non-mucin producing cysts, getting a really good clinical history and high quality axial imaging to figure out if it's pancreatitis related and it's serous cystadenoma or an SPN.
Okay, thanks for that breakdown, John. And I think that transitions well into my next question, which is the workup of the pancreatic cystic lesion. I think you brought up the two big points first and foremost. You have to have the good clinical history, and you want to get high quality imaging, whether it's a triphasic CT or an MRI or MRCP. What are some other things you may look for, like perhaps is there any lab work you might do? And when do you maybe consider pursuing a endoscopic ultrasound with a FNA?
Anytime we encounter hepatobiliary disease processes, a triphasic scan is really important. And so that includes an arterial, a venous, and a washout phase. For pancreatic cysts, it's important because you want to really establish if there's any sort of involvement of the vascular structure or the proximity to the vascular structures in terms of your operative planning. MRI, MRCP is helpful sometimes because patients don't want radiation exposure. And so that's a reason to think about it. And also, it gives you a really nice sort of representation of the ductal anatomy. So you can really begin to differentiate between, in terms of IPMN, if this is a side branch IPMN or a main duct IPMN or a mixed type IPMN. And so whenever a patient is found to have a cyst, and the vast majority of cysts are identified incidentally through a CAT scan, usually for some other purpose or for some symptom that might not be related, you want to then follow that up with the proper imaging study and kind of use that as your first test. In terms of lab work, I always like to have patients get a full set of LFTs just to make sure that there's no obstructive component. Sometimes patients will get tumor markers sent because the clinician that's sort of working this up doesn't know if it's pancreas cancer or not. And so a CA19-9 or a CEA may sort of make its way into the initial set of labs, but not essential by any means. And then I'm pretty selective about who I use EUS and FNA for. And as a young faculty, I've actually sort of leaned against using it because I found that there's a lot of variability in terms of the operators that are using them. And so what I mean by that is if you're going to use EUS FNA, you really want to have it be to make a decision about surgery or no surgery. And so I will be very specific in advocating that if a patient has multiple cysts, the cyst that sort of has the highest risk features is the one that gets sampled. And then I'll ask that in that analysis, cytology is sent and that's reviewed by a GI pathologist. And then I want to also know a CEA level within the cyst. I want to know an amylase level within the cyst and a glucose level within the cyst. And then I'm really an advocate for Pancreas-seq, which will evaluate some of the genetic markers of the cyst and give you a little bit more sense of exactly what this is if you're not exactly sure based on sort of your clinical history and your initial high quality imaging study, whether this is one of the mucin producing or non-mucin producing cysts. And so that's kind of how I break it down in terms of additional workup when I'm talking with the patient.
Thanks for that, John. And then just sticking with the like the cyst fluid analysis real quick, what are some of those canonical mutations that you are looking for and driver mutations that you're looking for and we should be aware of or wary of for pancreatic cystic lesions?
There's a good study that came out in the last couple of years that has looked at sort of patients with high-grade dysplasia, low-grade dysplasia, no dysplasia in pancreatic cysts. VHL is the mutation that's going to be seen in your serous cystadenomas. So if you catch that one, you're going to be able to very confidently say that this is a serous cystadenoma. And that might be helpful because men will often have atypical radiographically appearing SCAs, where rather than a microcystic or sort of honeycombing look with a central scar, it's very classic in older women. Men may have a unilocular cyst, or they'll have a very small one. And you're trying to say, is this IPMN or is this serous cystadenoma? And that will really help you make a decision because, oftentimes there won't be any additional surveillance or long-term follow-up. So that changes your decision-making altogether by getting that information. For IPMNs, I generally look for SMAD4, TP53, HIC3C, and a BRAF mutation. I think those are the ones that the field would generally sort of be a little bit more assertive about follow-up for. and not want to lose track of those cysts, even if they don't have necessarily other radiographic worrisome features. And then in terms of the biochemical analysis, the CEA proves that it is a mucin-producing cyst. So that's, again, very important. The amylase proves duct connectivity. So that, again, is going to be something you see in your IPMNs and your pseudocysts. And the glucose levels should be low in those, but high in a serous cystadenoma. And that's because serous cystadenomas have a cuboidal cell lining that often has glycogen vacuoles in it. And so it's a PAS-rich staining histologic section. So if you get sort of a little bit of a cocktail of your biochemical markers, as well as some of your mutations, if you see a GNAS or KRAS mutation, you know you're dealing with IPMN. Those things can all guide you to say, okay, I really know with confidence what I'm dealing with, and I get a little bit of prognostic information about whether this is more of an aggressive mucinous cyst or not.
Awesome. Thanks so much for that breakdown, Jon. So we've kind of discussed briefly the types of cysts and then the overall workup for them. So I just want to jump into our straightforward cysts, as you always used to call them, the ones that have a consistent clinical-demographic presentation and radiographic appearance, and the management is more, well, straightforward. The first one I want to start with is the pseudocyst. What is the history of this patient, and what is kind of the management that you would have for these patients?
Your pseudocyst patient is going to have a very clear or elicitable history of necrotizing pancreatitis, right? So you're going to ask all of the normal pancreatitis questions. So you're going to find out when they developed pain, what the pain occurred in the context of. You're going to find out how they're doing overall from a nutritional standpoint. You're going to have evaluated whether they, needed time in the intensive care unit or how many times they've come to the hospital with pain. And so once you kind of have that story and you get a CAT scan that shows a unilocular cyst that's often in sort of a retrogastric space, you can feel pretty confident that that patient has a pseudocyst. And then you're trying to evaluate, do they have any long-term symptoms related to that pseudocyst? So it takes a month probably for a pseudocyst to form. And if the patient's overall doing better, you just kind of watch and you see that patient and you make sure that they're kind of staying on the right path. But patients who begin to deviate from that and they are saying they have more early satiety, fullness, pain, weight loss, and there's a pseudocyst in sort of the context of maybe 6 to 8 weeks of their pancreatitis symptoms, you begin to think about targets to drain that cyst. And so those are patients who you would either talk to your gastroenterology colleagues about doing an endoscopic drainage, or thinking about doing a transgastric drainage, or doing a cystogenoscopy. So they're a very special class of patients that really don't live in the cyst discussion per se, because they're being managed as somebody who has sequelae of necrotizing pancreatitis or wall-off necrosis.
Okay, thanks for that, Jon. So the next one I want to go to then is the Mucinous Cystic Neoplasm, or the MCN. Who are we going to see this in, and what's the plan for them?
Your MCN patients, interestingly, are going to have a cyst that kind of looks like a pseudocyst because it's often unilocular. These generally are in the pancreatic body or tail, but they're going to lack the clinical history of pancreatitis. They generally are going to have some type of abdominal pain, maybe a little bit of left upper quadrant pain, fullness. And these patients are exclusively women. MCN is not a male pathology in any way. And that's because of the ovarian stroma that defines the MCN. And so there's probably some embryologic developmental issue that leads to the MCN forming in this particular space. And you're getting a very clear history in the right demographic and an imaging study that supports it. So often these don't need to be sampled because you have a good sense of what they are, but they could be. And these would be patients who have high CEA levels and no evidence of any sort of ductal communication, because it's a separate process through which this develops compared to something like an IPMN or a pseudocyst. I'd say overall, most people don't want to wait to operate on MCNs because they can progress to cancer. And when you know it, you don't really have to sort of think about it much longer, right? You just have to tell the patient, like, hey, this is the cyst that's going to be wicking forever. It will become a cancer. It's already big enough that it's causing you symptoms right now. And since generally these are presenting in middle-aged women, they're good surgical candidates. So a role for surveillance doesn't really make a lot of sense in these patients because all roads lead to Rome and these patients are going to need surgery at some point. So generally, this is a pretty easy discussion, and it's a good surgical candidate. When we catch these, it's before they developed any invasive component. But when an invasive component develops, these behave like bad pancreas cancers. And so, again, really dragging your feet with it doesn't make any sense. And surveillance doesn't really add much to sort of the decision making. It's just about sort of having an honest conversation with the patient that this is mucinous cyst that's going to become a cancer and we need to get this out. And often these are patients who need distal pancreatectomies. So they're great minimally invasive candidates, or they're going to just only lose the body and tail of their pancreas and do very well from that without all the sort of risks that come with a Whipple.
All right. And then last but not least of our straightforward pancreatic cyst is our serous cystadenoma, or the SCAs. Once again, who are the patients we see this in? What does it look like on imaging? And what are we going to do in these patients?
So this is generally a cyst found in older women. On imaging, like we had talked about, it has sort of this clustering appearance where there are many cysts in sort of this kind of cluster of grapes pattern, and there's generally a central scar. And so radiographically, this is kind of like a slam dunk when you see it. And often these are presenting in older women because they're a very indolent tumor, meaning that they grow very, very slowly over a long period of time. And so when you're catching these for symptoms, they've generally gotten quite large. When they've been found incidentally for another reason, they're small and they can be generally in the body and tail and not causing any symptoms. So in serous cystadenoma, there's no malignancy potential. If it's truly a serous cystadenoma with no mucinous features, it has no probability of becoming a cancer in any way. So I generally tell patients that this is a cyst that is going to be with you for life. And the only reason to ever do an operation for you is because you develop symptoms from this cyst becoming very large and beginning to compress adjacent structures. So a serous cystadenoma that grows in the pancreatic head that causes gastric outlet obstruction or biliary obstruction, yes, those are patients who are going to need surgery for palliative, quote unquote, purposes or symptom relief purposes, but not for an oncologic reason. And so these are cysts that you just have to be honest with patients about, like, you're going to have this. It's something that's on my radar. It doesn't really need to be on your radar. We're going to watch for symptom development, but there's no need to do surgery for this right now. In men who have serous cystadenoma, I might move them down the route of a biopsy to confirm it's a serous cystadenoma, because again, these can have an atypical presentation. And we had written a study back when I was a resident that showed many patients get surgery for serous cystadenomas because the surgeon is operating under the assumption that this is not a serous cystadenoma. So there is a little bit of an added benefit if you think there's any sort of radiographic feature that might hint that this is not an IPMN, and then you can reassure that patient after the biopsy comes back with either a VHL mutation or high glucose level or no CEA, that this is serous cystadenoma. We can do maybe a very curtailed amount of surveillance so that we don't have to do repeat biopsy or do surgery for you. And, that's good because it spares patients the pancreatectomies. So even though these are quote unquote straightforward, there's still a lot of decision making, a lot of patient counseling that goes along with it. And so having good imaging and pairing that with a history really allows you to sort of triage these into sort of the most likely diagnosis, though there can be these masqueraders that look more like an IPMN. And then those patients kind of get funneled into sort of the IPMN decision-making tree and then ultimately get surgery for it. And that's something you always have to be upfront with the patient about too.
Today's episode of the Behind the Knife podcast is brought to you by our presenting sponsor, Gore Medical Products Division. When it comes to ventral hernia repair in high BMI and comorbid patients, strength matters. Gore Cinecore biomaterial is a permanent mesh that is built like a lightweight, with the strength of a heavyweight and has 0 reported mesh fractures. With a less than 1% recurrence rate in ventral hernia working group grade 1 and 2 patients and a low rate of infection, Cinecore is designed to support your complex ventral hernia repairs. Visit goremedical.com/btkpod to learn more and ask your Gore representative about sizing and availability. Gore is Synacor biomaterial, no compromise for your high BMI and comorbid patients. Intended for U.S. audiences only, Gore is a financial sponsor of this podcast, which has been independently developed by the presenters and does not constitute medical advice from Gore. Always consult the instructions for use prior to using any medical device.
I think that's a great transition into our next portion of the episode, which is the IPMN, the cyst that's not as straightforward. There's a bit more nuanced decision making here, and I think the cyst that most of our listeners want to hear about because of all the nuances that go into it. So, John, the first thing that I want to ask you about is there's several different society guidelines for IPMNs. There's the 2022 Kyoto guidelines, the 2018 European Consensus guidelines, and the 2015 AGA guidelines. Could you just briefly break those down for us and talk about which ones you tend to use most in your practice?
Yeah, it's a great point because your gastroenterologists are going to generally lean on the AGA recommendations. The IAP, which produces either the Kyoto or the sort of seminal Sanday criteria, that's authored by surgeons and medical pancreatologists. And so that's what I usually use. And that is sort of revised on an iterative basis every, 5 years or so. And the main differences have to do with surveillance. And the difference there is that many IPMNs are small when they're diagnosed, and they remain small even on surveillance. And so the AGA guidelines generally, after 5 years of surveillance and relative stability, plus or minus US, will say no more surveillance overall for these cysts. The IAP, which has, again, surgeons sort of contributing to the decision-making and sort of how these algorithms are put together, know that there are cysts that will transform after some long period of time. The natural history of IPMN is unknown because we're never going to randomize patients to no treatment at any point, right? We also don't know exactly when the cyst starts, and the endpoint is when the patient passes away, which could be from another cause. So the scope of IPMN surveillance has to span a longer time because we know that these cysts aren't transforming on a 5-year basis. It's a 15-year process. And so the IAP basically is advocating for long-term surveillance and surgically fit patients. And so that's the framework that I generally use because we've all seen cysts that kind of look fine for 8 years, and then 10 years is when the transformation happens. And if the patient is still surgical candidate, well, you're going to do surgery for that patient because you're going to get this thing out before it becomes a bona fide cancer. And so that's the main difference in between the frameworks. The European guidelines will kind of discuss all cysts and kind of have a little bit more gray zone between what they're talking about, but because they'll factor in cystic neuroendocrine tumors, they'll talk about MCNs, they'll talk a little bit about Serous Cystadenomas, but really the IAP is focused on IPMN management. And I think like we tried to break down, there are cysts that we kind of know what to do in sort of a straightforward pattern, and then there's IPMN. Right. And so that's why I think IAP's guidelines are the most valuable for surgeons making decisions about IPMN.
Okay, understood. So, John, when you're making the decisions for a patient who you see that has an IPMN, what are some of the important factors that you consider?
The first thing I do is I look at the size of the IPMN and I look for the presence of worrisome features. So worrisome features are defined and they've changed over time, but cyst size greater than 3 centimeters, growth rate 2.5 millimeters per year, though I'd say that some people will say 5 millimeters per year. So there's a little bit of wiggle room there. It looks at the size of the pancreatic duct, and that is helpful because dilated pancreatic duct could mean a main duct IPMN, which is a little bit of a different flavor of IPMN. Which are more commonly side branch IPMNs. It's the evaluation of peripancreatic lymphadenopathy. It's looking at the patient's CA19 level, and it's looking for internal septations or neuromodularity, things that would suggest that this tumor has either harbors a solid component or is on sort of a trajectory that I have some radiographic surrogates for representing that malignant transformation. So I look for those things, and I have good radiologists that will sort of, type those into the computer for me. And so it's a little bit easy to sort of compare across studies, size and growth rate. But then I also really want to know, what operation would this patient need? Do they need a Whipple, or do they need a distal pancreatectomy? Or could I do a central pancreatectomy for them? How old is the patient, and what are their comorbidities? Are they ill, or are they fit? And then I look at their age. Are they a young patient with this diagnosis or a new patient with this diagnosis? Because all that's going to factor into the decision making about how often to surveil these patients and how long to do that surveillance for. And so that becomes a real recipe. There's a lot of decision making that goes into it. And I try to weigh all those different features to sort of make that decision about surveillance versus resection. Now, IPMNs that have high risk stigmata, they generally are just going to go straight to the operating room. And that's the duct that's greater than a centimeter. Those are the patients who have jaundice. Those are the patients who had a biopsy that's already shown high grade dysplasia. There's really not much of a discussion to have there as long as they're a surgical candidate. If they're not a surgical candidate and they don't have a biopsy, I generally will get tissue to see if I can capture some dysplasia or one of these high risk features so that I can make a more informed decision about that patient going to the operating room. And so that's kind of how I take all clinical radiographic factors and sort of pretest probability of these cysts having a malignancy and making a decision about OR or not.
Thanks for that, Jon. That's a great breakdown. And just for the more junior listeners, Jon talked about how he factors in which operation the patient may need, and that operation will just depend on the location of the cyst. If it's in the head, the patient will get a Whipple. If it's in the pancreatic neck, it could be a central versus a subtotal pancreatectomy. And then if it's in the tail, obviously a distal pancreatectomy. But I think the big thing that we want everyone to get away from this talk is that when you're deciding on surgery for an IPMN, you have to balance the risk of high-grade dysplasia based on those worrisome features or high-risk stigmata with the patient's age, their comorbidities, their performance status, and also the extent of the operation that they're going to require. And so moving forward with that, Jon, we talked about surgery versus surveillance. But one question that I have is, when do you need to stop your surveillance? Do I need to follow a patient for 10 years, 20 years? When is a good time to say, okay, you don't need to keep coming to my pancreatology clinic?
So I basically draw the line after 10 years of surveillance for very small cysts. So the cysts that are kind of in the sub-centimeter group, they generally don't have any sort of risk of progression. And we have a paper that showed that these small cysts don't change in any appreciable way after 5 years if they hadn't changed already. So kind of 10 years of the rule of thumb for the sub-centimeters. The rest of them, it's when you're no longer a surgical candidate. So the octogenarians, I will generally say we're going to watch things up until you're about 85 if you're a surgical candidate. And if they sort of don't have any meaningful change or they don't develop any worse features and they turn 85 and the cyst is 2 centimeters, I think that their risk of this progressing to a cancer is unlikely in their lifetime, and something else will outpace them in terms of their overall survival. And so that's kind of where I say enough is enough. I often will space out the interval of surveillance once patients are getting up towards 80 years old and they've had relative stability in their cyst up until that point. So I usually will I'll do one round of when the cyst is found, a round of imaging at 6 months to prove whether this is growing at some fast pace or not. And then I'll do surveillance on a yearly basis for 5 years. And if there's no change in the cyst, I'll begin to do every 2 year surveillance. And then I try to get to that 10-year number, or they turn 85, right? And I say surgery is just no longer in the cards for you. And to your point that you raised before, all these operations are prophylactic. We're intending to do surgery before this has transformed into invasive cancer. And so that's really, really important in sort of the decision making. because we have no perfect test for IPMN that's going to prove that this is or this isn't cancer without a biopsy proving that it is. And if we get to that point, we've already missed the boat because it's already gotten beyond the point of needing surveillance, right? We're doing an oncologic operation, and IPMN generally behave better than PDAC itself, but it's still PDAC, and it still has a 50% 5-year overall survival. And so the goal is to use all of these clues and hints and guidelines and clinical gestalt and weighing that against sort of the morbidity of the operation to say, I'm going to intervene at the moment where I think that the probability of this being cancer is the highest. And so I have a really good example of this where there's a lot of decision making that goes into it. I have a patient who's 82, who's been followed for over 5 years. And in the last year, the cyst has grown significantly. It's grown 5 millimeters. It's now greater than 3 centimeters. There's a little bit of pancreatic duct dilation associated with it, the 5 or 6 millimeters or so. And so this is somebody who, if they were 52, would just be going to the operating room. But in this patient who's older and has relatively good performance status, but I know that they need a Whipple, I have to be very careful about the decision making of that patient because it could have a major impact in that patient's quality of life. So that's somebody who I want to add the EUS to the decision tree to see if I can capture any high risk or high grade dysplasia in the cyst, any mutations in the cyst, something that gives me a little more certainty that this is the moment to intervene. Because if I do another round of surveillance and there's minimal change, well, now the patient's lost 2 years of maybe good functional status where I could have done a Whipple 2 years prior. So that's where a lot of the decision-making, counseling, and art of this comes in, where you're really trying to thread a needle and make a perfect decision for that patient at that particular time. And again, this is where, having a minimally invasive approach makes a huge difference, because if I can offer someone a minimally invasive Whipple or an open Whipple in their 80s or an IPMN, which is a prophylactic operation, gives me a little bit more of a push to do that for them. And so having a wide skill set, having sort of really honest conversations with patients, reviewing all of the data and sort of making a decision and adding additional data really sort of, I think, highlight the complexity of making decisions about patients with IPMN. And the last thing I'll say, just as a plug, is that symptomatic patients with IPMN are a little bit of a different flavor. And so there's a lot of overlap between patients who have IPMN, an episode of pancreatitis, and a duct that looks like chronic pancreatitis. And so those are another special group of patients where I do a lot of counseling to try to tease out, is this a patient with chronic pancreatitis? Where the patient has an IPMN that's causing pancreatitis, and they've had so many episodes that they now have chronic pancreatitis. But a lot of cool decision-making that goes into that, and deciding the right operation for that patient is a little bit more nuanced. And they may be someone who gets a limited resection with some type of ductography, or you find out that this really is an IPMN, it's really just chronic pancreatitis, and then you're talking about a drainage procedure for that patient. So again, there's a lot that goes into sort of how you think about the IPMN, and all of these are very individualized discussions.
Yeah, certainly. I mean, it's very obvious that and why IPMNs are not in our straightforward cyst category. One question additionally that I did have, Jon, is do you need to do surveillance for patients after they've had a resection of their IPMN?
That's a great question, and the answer is yes. And so there's a little bit of a conundrum here, where like you're doing surveillance and then an operation to do more surveillance versus to doing surveillance, right? And so again, it gets to the point that you really want to do an operation at the moment you think that there's a very high pretest probability of there being dysplasia, high-grade dysplasia. But yes, patients do need surveillance after they have their IPMN resected, because there is a risk of a new IPMN forming, a pancreatic cancer developing, or a known IPMN progressing. And surveillance is generally conducted on a yearly basis. Again, it's either a CT triphasic or a pancreas protocoled MRCP. And after 3 or 5 years, you're generally free and clear of there being a recurrence if you haven't had one already. And so I did a big meta-analysis looking at this, and that's kind of the amount of time after an initial resection that if you're going to get another IPMN that warrants an operation, that's the timeline that it occurs in. But again, you're going to carry out surveillance only until this patient is no longer a surgical candidate. So in general, you've had a patient who's been in surveillance for a long time, they get an operation, and so probably they're elderly by the time they've had their first, maybe 3 or 4 year worth of imaging after their IPMN comes out. And so probably at that point, they're in their 80s or they're elderly, and you're just not going to do any more surveillance. And so that's when you generally feel pretty confident about calling it, because you've found the bad actor, you've proven that no bad actors have kind of cropped back up on the scene, and then you've done your appropriate amount of surveillance, gotten this person to a point where it really doesn't make sense to do any more surveillance because they're not a surgical candidate anymore.
Okay, understood. Honestly, Jon, thanks again for this great talk. And for all the listeners, I know we alluded to some papers, but we'll definitely include those links in the show notes. And so before we leave, I want to leave you with some key takeaways, and you'll notice that these are themes that have come up again and again in our discussion. The first is that pancreatic cysts are common, and understanding the risk of malignancy is imperative. You want to start with high-quality imaging to help determine the etiology and assess for malignancy risk factors. If the cysts are equivocal or suspicious for malignancy, definitely utilize advanced diagnostics like endoscopic ultrasound and FNA with cyst genetics. And as Jon has mentioned, a thoughtful surveillance strategy, when applicable, is important in non-operative and also post-op settings. And lastly, and we've mentioned this a lot, when considering surgery for a patient, you need to take into account multiple factors: their age, their surgical fitness, the extent of the operation, symptoms, and the diagnostic certainty and risk of malignancy from their cysts. And so with that, we want to thank everyone for tuning in, and as always, dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.